And you're listening to Victory Talk Radio here on Victory Radio, and I'm John Baldwin, your host for the next hour. And tonight I have a very special guest and good friend, Daniel Rowley, who is a respiratory therapist. He is an MSc, RRT-ACCS, NPS, RPFT, FAARC. Boy, that sounds impressive. I'm going to let him explain what those are. Welcome, Daniel.
Thank you, John. It's great to be on your show today. Yes, I am a respiratory therapist at the University of Virginia Medical Center in Charlottesville. And those acronyms after my name are basically just professional education and certifications that I've acquired over my career. I have a Master of Science in Respiratory Care Leadership from Northeastern University in Boston, Massachusetts. And then as a registered respiratory therapist, I am an RRT with specialty credentials in adult critical care as well as in neonatal pediatrics. And the last credential, which is the FAARC, that's a designation that's bestowed upon leaders in the respiratory therapy profession, which identifies us as fellows of the American Association for Respiratory Care because of our sustained and significant contributions to the art and science of the field.
Wow. Well, it still sounds impressive. And before we get started with the interview, we're going to be talking about a fantastic and fascinating study you're doing in respiratory therapy. I do want to mention to the audience, and I have not talked about this on the show at all. Earlier this year, I was diagnosed with having a softball-sized tumor on my duodenum. I think that's how you pronounce it. Anyway, it's in the small intestine area. And it required Whipple surgery to get it out. It was a major surgery. I was on the operating table for about 8 hours and did it at UVA and was there for about 5 days in the hospital. While I was there in the hospital, I was approached and asked if I would be a volunteer in a new respiratory study that they were doing there at UVA, and I gladly accepted. And because of that, I met Daniel, and we became good friends. And he not only did the study, he was there for me, during this whole process. I was not exactly feeling in the greatest of spirits while I was in the hospital. And there were a couple of times Daniel just sat and listened while I vented and poured my heart out. And I want to thank you for that. That meant a lot to me when I was there.
Well, thank you. It meant a lot to me and still does mean a lot to me that I had an opportunity to not only meet you, but to get to know you, John, while you were going through a really difficult time in your life. And I'm glad that we were brought together under those circumstances for me to be able to provide care for you, but also to maintain a lasting and developing friendship. So thank you.
What led you to a career in respiratory therapy?
It was kind of fortuitous. I knew that I would go into a healthcare-related field, but not necessarily respiratory care. I was unaware of respiratory care, and I kind of stumbled into it. And when I went up to one of the local colleges where I grew up in Seattle, Washington, I met one of the program directors who immediately and enthusiastically described to me the roles and responsibilities of a respiratory therapist. And after spending some time talking with him and looking over the curriculum, I knew that it was heavily based on science and heavily based on caring for critically ill patients, mostly focusing on not only diagnostics, but care of the critically ill patient. This is something that definitely sparked my interest. And the next thing I knew, I was in the program.
Wow. Now, how many years of college did it take to go through all that and to graduate and get your degree?
Yeah, that's a great question. Just like nursing, the entry level for the profession of respiratory therapy can occur on different levels. There's 2-year programs, which means that after finishing 1 year of didactic coursework in anatomy, physiology, some of your core basic sciences like chemistry and physics, and then some of your social classes, then you enter into the respiratory care program and then graduate with an associate degree. And then there's, of course, baccalaureate degree and then master degree completion programs.
And kind of fill in the blank, because I know you, of course, you're at UVA and know you from there. What, between the time you finished college, describe for us what happened to bring you to UVA, and how long have you been with UVA?
Great. Yeah, so I actually came to the University of Virginia almost immediately after graduation. I finished an internship in Seattle at Harborview Medical Center, which is a large trauma center. And then I started to interview around the country at what was then very well-known departments where the respiratory therapist had a very active role in clinical practice, but also publishing cutting-edge research in terms of trying to advance the art and science of the practice. So I moved out to Charlottesville to work at University of Virginia in 1993. So I've been working at UVA for almost 25 years.
Wow. And unfortunately, in that time, their football team still hasn't won a national championship.
Yeah. And it's kind of sad. We still pride ourselves on academics, but there's many great universities out there that are not only academically suitable, but also athletically. We have some catching up to do.
Well, you came in at a time, though, in the mid-'90s, though, they were pretty good back then under George Wells. They were like number one in the country one year, and then they blew it against Georgia Tech.
Yeah, they've always given us trouble, but we got them this past week, so we're pretty happy about that.
Yeah. Well, give us a history and background on this current study you're conducting.
Absolutely. So my background in respiratory care, like I said, is adult critical care. But outside of adult critical care, I oftentimes see many post-operative patients, and some of those post-operative patients, such as yourself, had extensive surgery within their abdomen. And we tend to, as respiratory therapists, see these patients after abdominal surgeries because they're at very high risk of developing post-operative breathing problems, secondary to either the surgical procedure that results in the diaphragm being pushed further up into the chest wall, or from pain. So if we're not taking in deep breaths because of pain and we don't have adequate pain control, what will happen over time is parts of our lungs can start to deflate or collapse, a condition known as atelectasis. And as we develop atelectasis, then what happens is the amount of oxygen the amount of oxygen that is exchanging within the lungs into the bloodstream is less available in terms of the surface area of transfer of that gas. So it starts shunting, and then our lungs start to collapse. And we only have global parameters to really identify when that happens, such as looking at oxygen saturations non-invasively with an oxygen probe we put on people's fingers usually. That just gives us kind of a general idea of how well a person's oxygenating. If we start being suspicious of lung collapse, we can auscultate or listen to a patient's chest wall and hear maybe decreased breath sounds in a certain region. That would raise suspicion for maybe a chest x-ray. If we get a chest x-ray, that might actually tell us that somebody does have this lung collapse in a certain region. But we're exposing these patients to radiation, and what we're trying to do is avoid that. When I was at a medical conference about 2 or 3 years ago, I came into contact with some colleagues I knew from a major medical research and development and distributor company known as Draeger. They're located out of Lübeck, Germany, and they have a non-invasive monitoring tool that allows us to take a look at regional distribution of ventilation without using radiation, and also in real time. And I immediately started thinking, this is something I might be interested in exploring here at UVA for research purposes. So I started doing some research on this device, known as the Pluma Vista 500, and I see that it was not approved for use in the United States by the Food and Drug Administration, but it could be utilized for research purposes. So I started thinking, well, most of the research that's being done in this area with electrical impedance tomography is done in the ICU with mechanically ventilated patients. And not anybody that I have come across in the literature yet has really focused in on patients who have had post-operative abdominal surgery. So I started thinking about the therapies that we provide because there's just not a lot of strong evidence to support some of the stuff that we do in terms of either preventing or trying to reverse lung collapse, such as atelectasis. And I thought this advice would give us a real-time view as to what was going on in the lungs before we started those treatments, such as incentive spirometry, where somebody's asked to take in a couple of big, deep breaths over a certain period of time and hopefully expand those lungs. And then we compare it with another device. Instead of taking a big, deep breath, we actually, as we blow out, we push air into the lungs to try to inflate them. And by using this electrical impedance tomography monitor, we're able to actually get a real-time view as to whether or not the therapies that we're doing are A, effective, and then B, try to examine how the distribution of ventilation is occurring throughout the lungs.
And I can tell you, having been part of that study and watching the monitors as you were doing it on me, that is just fascinating to watch, because you can see the colors change on the screen as the air fills your lungs and then leaves your lungs. I'll admit I don't understand it all, but I'm fascinated by it.
Yeah. Well, I can give your listeners kind of just a general overview in terms of how it operates. So essentially, think about a sonar. That's how one of my study investigators likes to describe it to people. You met Joe. So Joe's a respiratory therapist, and one thing that he likes to do while getting consent from people who want to participate in our study is describe this device as a sonar device in a sense. And essentially what we do is we have this elastic band that fits around the chest wall and clamps over by the breastbone, and it has electrodes that surround the chest wall, kind of like an EKG electrode that's embedded into this belt. And then those electrodes essentially are connected to a cable that's connected to this monitor, and that's the Poma Vista 500 I was talking about, and it provides real-time regional information of ventilation through the lungs. And we know that air is a good resistor to electrical current flow. So what we do is we inject a very low current of electricity through the body that's not felt by any of our participants. And then we can see as the air, as the lungs begin to inflate with air, we recognize there's more resistance to electrical flow, and that's how we get these tomographic views of the lungs. So unlike a chest CT, which uses radiation and gives us really, really good spatial resolution, the electrical impedance tomography device doesn't give us good spatial resolution and only gives us a pixel range of about 32 by 32 pixels, as opposed to a CT scan that gives over 512 by 512 resolution. So we don't have the anatomical resolution that a CT scan will have, but it will actually give us a nice map and view of where the resistance of electricity is so that we can see which parts of the lungs are inflating with air or being resisted to air for some other conditions.
Right. Now, I know the device that you mentioned, I couldn't possibly repeat the name, but I actually felt a benefit from using it, because when I was using the device, I was able to breathe easier while you were doing the study on me.
Yeah, so there's two devices that we use. We can use a device that's considered a real standard of care in most post-operative patients, whether or not you've had knee surgery, chest surgery, or abdominal surgery, known as an incentive spirometer. So for those of your listeners who've ever had surgery or have a friend who had surgery, those are those things that a healthcare provider will bring into your room and say, hey, I would like for you to take 10 breaths per hour, for instance, through this little device, and it has a tube connected to this device with a mouthpiece. And what happens is as the subject or the participant in a study or postoperatively begins to inspire, we have this volumetric measurement of how much air we're inspiring into the lung. And the intent of that is to expand the lungs and give you an objective measurement as to the effectiveness of your breathing in. Okay? The device that you had is a little bit different. It's known as a positive expiratory pressure device, and we use one that's labeled as EasyPap. And what that does is not asking you to take in big deep breaths, but while you're breathing out, it provides you with resistance to breathing out, so it kind of forces air back into your lungs with hopes of it recruiting parts of your lungs that may be actually collapsing, so that we can get better surface area distribution of ventilation.
Right.
And the way I like to describe this is that if you were driving down the road with a convertible car, let's say, or you're sticking your head out the window at a high speed, you can feel all that air that's rushing at your face. That's what that positive expiratory device might have felt like. And yes, the sensation that you felt is exactly what we anticipate you might feel. If there's a therapeutic effect or not, that's what we're trying to determine.
Wow. After the interview, I'm going to go out in my car and roll the window down and roll down the street. I won't do that.
It's cold tonight. Be careful.
People, folks listening, don't try this at home. Okay. That's my
That's right.
my warning for the night. Well,
Yeah.
if someone takes part in the study, how long do you study the person over a period of time?
Yeah. Okay. So for this particular study, we're going to start monitoring on postoperative day 1, and then we're going to monitor them up through postoperative day 5. And the reason we only measure post-op days 1 through 5 is because based on the literature, we know that this is the time frame that most of our patients who've had upper abdominal surgery run into postoperative breathing problems. So if we can kind of measure what's going on during that window and compare the two therapies, that will hopefully either reverse or prevent the lung collapse or help to remove secretions or help patients move secretions out of their airways, we might be able to prevent it. So up to postoperative day 5.
Right. Well, I'm telling you, not only what you did, but the whole staff at UVA is just, I have nothing but praise for them. Everything that they did with me, of course they do this, they've got all the science, so to speak, down to a T, and they, the nurses staff knows what to do, and they know exactly how to react to any situation. So I was just amazed. And
well, thank you. We've become a pretty well-oiled machine, and we look for opportunities to improve every day. You may have remembered us asking you frequently, several times a day, mm-hmm. Are you in pain on a scale of 0 to 10, with 0 being no pain and 10 being the most pain that you've ever had? Where's your pain? Because we want to make sure that you're comfortable, first of all, okay? Because if you're not comfortable and pain-free, meaning on a scale of 0 to 10, if your pain level is greater than a 4, we want to ask you if you would like some pain medication so that you can participate in the post-operative rehabilitation. That includes not only deep breathing and the stuff that we're doing with you, but physical therapy and nursing therapy, getting you up and ambulating, walking down the hallway.
Right. And that's one thing that, that's changed, over the years. It used to be when you had surgery or something, the prescription was rest. But I remember they had me up the next morning walking the halls with my walker, and I was ready for it. They told me beforehand, "So be ready for this. They're going to want you up and around like the next morning." And I scared Dr. Zaifudum because, and he's my doctor, by the way, the surgeon I had. He came in the next morning and said, "How you doing?" And of course they drill into this, be ready to go walk. And so I'm like, "Oh, I'm ready to go," meaning going walking. But I just said, "I'm ready to go." And he goes, Go where?" He thought I meant go home. No. I mean, go walking down the hall. I am in no condition to go home. Even if you want me to go home, I'm not moving from this hospital. So anyway.
Yeah, I do remember you walking down the halls, and you were very active and participated very, very well in during your stay and in your recovery, and that was good to see, because I think really ambulation can help a lot. There's been a huge national movement towards early mobility in post-operative patients because we're looking at more functional recovery, and that's been documented if we can get people up and moving sooner than later.
I know you mentioned, the people who are that you're studying have abdominal surgery, but within that, is there a subgroup that you determine who to include in your study?
Yeah, so in terms of inclusion criteria, we've tried to keep it pretty general. They have to be adult human subjects, greater than 8 or at least 18 years of age, but not over 79 years of age. And then we certainly want to make sure that the surgeons given consent for approval of their patient's participation if the patient wants to participate, and then just ability of the patient to follow commands in terms of understanding the consent process and really understanding what we're doing in the study. The types of surgeries that we're actually seeing, the majority of them are Whipples, such as what you described you having. We've seen patients who've had liver resections, known as a partial hepatectomy. We've had a lot of pancreatectomies. So most of our patients have had some form of abdominal cancer, and that's oftentimes localized in this study to the upper part of the abdomen.
And what are the primary and secondary goals of the study overall once you've accomplished everything?
So the primary goal really is we believe that we're going to get some important information that can be gained from EIT measurements, looking at regional distribution, ventilation, and some of the changes that can occur in parts of the lungs that we're not able to see right now in real time, non-invasively. We think that some patients may actually benefit from our findings, whether or not we see advantages or no advantages comparing these devices. And then also help clinicians better understand the association really with therapies that we're looking at. It's also going to help us so that we think that we may be able to reduce the use of kind of clinically ineffective lung expansion therapies and better utilize our resources, certainly if we're not seeing an effect that's making any difference in terms of positive outcomes for patients.
Right. Now, how far along are you in the study at this point?
So just this week, we've enrolled our 56th participant out of 100. Mm-hmm. So we're just beyond the halfway mark. And my study team, consisting of my director of respiratory therapy, Thomas Malinowski, myself, our medical director at University of Virginia, Dr. Kyle Infield, who's a board-certified pulmonologist, and then Daniel Goetnauer, a respiratory therapist, and of course Joe DePepe. We'll get together, start looking at our data since we're almost at the or just beyond our halfway mark, to kind of see if we're starting to see trends emerging in our data as we get closer to finishing.
And what is your timeline-wise? When are you hoping to finish?
Yeah, our goal is to finish by January of 2019, and we're probably about 3 months ahead of schedule right now because we've seen a lot of enthusiasm from the surgeons who are allowing us to approach their patients to invite people to participate in our study. And then out of the people that we have approached, which up to today was a total of 76 persons, we've had 56 yeses who've been enrolled and consented to participate. So the participation has been very good up to this point.
Now, once the study is done, what do you have to do afterwards to have it published?
Yeah, very good question. So what will happen is once we are complete with the study, our study team will get together, we'll look over the data, and then we'll start writing the paper, which most of the background methodology has already been written, of course, because we go through an institutional review board review before we can actually conduct the study. Okay, so they look at the study quality and they really look at the safety of the study and the methods being used. So the method section is pretty much written already. So what we'll do is then start writing the manuscript, including the results, and then the discussion part of the paper. That's very important, where we compare our results to other published results that are related to the type of research that we're doing. And then we submit it to a medical journal of our choice. We will go to a peer-reviewed medical journal because that's very important, because it adds credibility to what we're actually publishing, because you have other experts in the field reviewing your manuscript saying, yeah, this is good science, the methods look good, this is worth sharing, and then we hope to get published so that we can then share our results with the general public. And I mean general public, not just locally, but internationally through the medical journal.
Awesome. And how long does that normally take to put all that together after the fact?
Yeah, the way that our team works, I'm thinking that after the study, we should have a solid draft done within 2 to 3 months. So I'm looking at spring of 2019, submitting our article or manuscript, and we've already chosen the journal that we would like to submit to, and it's the Journal of Respiratory Care, which is a peer-reviewed journal and part of the American Association for Respiratory Care. Has a broad readership, and that focuses on respiratory care. So that's why we've chosen that journal.
Well, in all the studies you've done, not just in this current study, but through school and being a respiratory therapist, what have you found that astounds you most about the human body?
The complexity of the human body, but the body's ability to repair itself is unbelievable. For instance, when our body is invaded with, let's say, bacteria, our immune system immediately responds by releasing cells that fight bacteria, but it also can cause an inflammatory response that can be dangerous too. So it's very interesting when we start looking at the immune system's response, but also how resistant our body is to invasions. So I think that's been the most impressive thing that I've seen as a respiratory therapist in my years of practice, but also the ability of the body to heal on its own or with some type of medical interventions.
Right. Well, you went this summer. You got a chance to go to China. Tell us about that in the correspondence you have there.
Oh, sure, absolutely. Thanks for asking. So I have some contacts in China because through the American Association for Respiratory Care, I'm on the international committee. I'm actually the vice chair of the international committee, and by being involved with the international respiratory care community, I get to meet other leaders and stakeholders within respiratory care, and over time, we begin to not only communicate, but try to identify areas that we have sharing with each other. And as a result, I've been invited back to China now, I think it's 4 or 5 years in a row, and to Hangzhou to work with a group of respiratory therapists and physicians at Sir Runrun Shaw Hospital. And a colleague of mine at University of Virginia, Ryan Sharkey, has joined me there. And what we do is we go there and we provide education related to clinical practice. Sometimes they have new employees starting there, where respiratory therapy is a young field that's very much developing quickly. So we provide anywhere from anatomy and physiology presentations to patient assessment and diagnostics, whether it's basic or advanced diagnostics. And then we also speak at several conferences around the region, ranging anywhere from Southeast China all the way up to Northeast China up into Beijing.
Wow. Well, if there were folks listening that might, thinking about, young folks that are thinking about a career in science or even respiratory therapy, what advice would you give them?
My advice is to contact a respiratory therapy department in your region and ask if you can actually observe a respiratory therapy practice for an hour, 2 hours, so you can spend time with the respiratory therapist to get an idea what the job entails. We're really a mixture of skill sets between a doctor who specializes in lung disorders, an ER physician who performs lots of procedures in emergent situations, and an anesthesiologist who actually takes care of mechanically ventilated patients and does a lot of airway stuff. So being able to get into a variety of different situations where you're working with premature infants with underdeveloped lungs, pediatric patients with cystic fibrosis, or the elderly receiving palliative care, try to see what all that looks like, because it's not for everybody, but for those who really do see the practice of respiratory care, if it looks like it's something for you, it can be a lifelong commitment to really helping change the lives of a lot of people.
Well, Daniel, I'm just so fascinated by the work you're doing. Again, we're talking with Daniel Rowley, and he's been telling us all about this wonderful line of work he's in with respiratory therapy. Thank you so much for coming on the show and sharing all this information with us.
John, it's been a pleasure. Thanks again. And again, if it wasn't for me meeting you under your circumstances, we wouldn't be having this conversation today, and I'm very glad that we are.
I am too.
Glad your recovery is going well.
Thank you for everything you did for me while I was up there. I had so many different people looking after me and praying for me, and I am very humbled by the whole thing. And it also shows you the brevity of life. So you got to grab life by the horns like you're doing, and do what you love doing. Don't waste time taking things for granted or doing frivolous things that don't really make a difference in people's lives.
Yeah, absolutely. And, the study really, I wanted to make sure that you're aware that it would not be possible without the participation of people who are very ill at the time that we actually approach them for participating. So we do not take that lightly. And I want to thank any of the listeners out there who may have participated in this study so far, or those who may be interested in participating. If you're having an upper abdominal surgery at University of Virginia, to talk to your surgeon about this. And there's a possibility that during your post-operative day one or just before surgery, you may get approached to learn more about it.
All right. And when you're, let me know when your study is in the peer-reviewed journal. We'll have you back on at least to tell us where it is and where folks can go and find it.
I would love to. Thanks a lot for that invitation. I'll definitely follow up on it.